All right. Let's get the lappy toppy going. Hey, Tasha. How's it going? Oh, let's see. Let me know what you want to see in today's live, what you want to go over. Just waiting for a few more people to log on. Definitely don't need that. Which exam is this one? Part 1. This is part 2. I'm doing great. It's been a crazy day. Been busy. Busy. Hobby Lobby has gathered all the district managers and everybody down to Phoenix for today and tomorrow. So hubby's out of town, so I'm doing all the cleaning that would normally disturb him in his routine so that I can get all the bedding and beds, baking soda powder on them, and, flipping mattresses and doing all that stuff. And I got all night to wash sheets and blankets and stuff so that I get that done. My mom got us one of those litter robots. It's a fancy little thing that does all the cat litter maintenance for you, but that ball thing is quite crazy to clean, so you have to take it outside and wash it with a water hose and stuff. So that's always an ordeal. So I did that today too. So kind of had my eye off the ball today, not working on my 2022 guidelines, which I should be cramming on, but I kind of needed to get this stuff done so that he doesn't get any days off between Halloween and the new year, because it's retail at Hobby Lobby when you own one of those stores, and you have to be there, and there's no days off during the whole time from October to March. All vacations and time off is embargoed. Gotta love the way they treat their staff. They don't let them have any holiday time off at all. So if they want any vacation time, they have to take it after inventory and stuff in the beginning of the year. So that will happen come April through July is when he can use his 4 or 5 weeks of vacation time for whatever we want to do. But it's a little nice to have him out of the house overnight just to get some things done. That's terrible to say, but I'll miss him later on. Right now it's good getting some stuff done. I did, I don't know if anybody's noticed the out-of-sequence codes, that are all throughout here, where they're that red thing that tells you go look between these codes and that code to see if you can find the code, and will tell you where it's at. And I always recommend writing the page number down where they're at. If they're on the same page, I just draw a line down to the code. But there's also an index in the back of the book that has a list of every single one of the out-of-sequence codes and where to find it. like that's super helpful. They should just put a page number down. Well, I went through the entire index and wrote them all out. I have that up now on the Etsy store if anybody wants it. But for 2022, I'll have it typed out so it's easier for everybody to read instead of my handy-dandy handwriting. That's pretty crappy. And plus, when you take a picture and then you turn it into a PDF, sometimes it gets blurry and stuff. So having it all typed, which I'm going to do for all the CPT book next year too, will be easier for everybody to see, and I won't get complaints of blurriness. I'm just trying to help, but it is a lot of work. But just in case, I'm not sure how many people I have in here. Let's see, I gotta adjust this because it pops up. I got 9 in here. Okay. So just in case anybody's new to me or knew what's going on, I help people pass this AAPC CPC exam. I also try to help people that are doing the AHEMA, the CCA or CCS if I can. Their exams are a little bit different. A lot of it's the same. But for the AAPC, I audited their course and their exam, and I've been mentoring people since end of April of this year and finding out what test questions they're asking, what routine information is always on there, and fixing. This CPT book has turned out to be pretty key in getting this test done. Over 100 questions are directly of a 150 question test are from the CPC exam. You're going to have 10 that are ICD10s. You'll have 5 or 6 that are Hpcps. You'll have some regulation and some regulatory and some guideline and anatomy questions for the last 40 or so questions there out of the last 50. But over 100 questions are going to be in the CPT book. And if we can prep this book, I found that I can get people to pass their first try if they get everything done ahead of time, especially on their second try, if they're with me long enough for sure. You need to be sure and get your core codes boxed with your child codes that go underneath it. There's even in the front of your CPT book, it tells you how to use this book, instructions for using the book, and it tells you about the boxing. It tells you what to highlight. It shows you exactly what to note after that semicolon right there. So what you do is, after you box and highlight every code throughout this book that has a child code, meaning that the indentation is over, not directly underneath the CPT code, and then once you get another code that is back over to the same highlight, then you know you've started over with another one. Some of the codes are going to go over to the new column, which I just use this method of arrows to note where the parent one is. If it goes over to the next page, I have arrows pointing that way. The main thing is to highlight what's after the tiny little semicolon in the parent code for sure, and then you're going to highlight what's in the child code up to the parentheses. The parentheses you don't have to do. This is just additional information that goes along with what's going on in here to give you more information. You need to note in your parenthetical notes underneath codes that tell you when to use a modifier, when not to. They're also going to tell you when not to use modifiers. They're also going to tell you when to use codes with codes, and they're also going to tell you when not to use codes with codes. So I try to keep it in some sort of uniform formation. Blues are good. Reds mean stop. I I also try to do, and I recommend everybody that I mentor, take 2 codes from each page, find you a clinical example that's using those codes properly, either with modifiers or just those codes alone. Even if you get the ICD10 codes to go along with it, that's great. Write you a little scenario down. This is just a lumbar sacral. They have spondylosis, and they did a procedure without the myopathy surgery. They did it bilaterally, and they used a posterior approach. So the code that they used was the CPT code. They used the bilateral modifier, and they used this diagnosis code. If you do 2 examples per page, you're going to be rocking that exam for sure. My pink highlights on my books are codes that were used in my CPC exam or somebody I've mentored, and I try to do those codes on the pages that I've done. Try to find examples or try to remember what the question was that was on my exam, or going through the AAPC course or the COC course, or previous exams that are posted online, and their practice exams. I try to find good examples. I try not to get the ones on Quizlets, whatever that is. I found a few errors there. So it's a good tool to practice, but just be sure and know for sure whether codes are appropriate or not. Also, in the CPT book, I don't know if you've noticed, there's also these little things at the bottom that says CPC changes an insider view or CPT assistant, and they tell you the year and date it was published. So I get those books too, and go find the codes that they're talking about, because what they do is they publish, if they find out that somebody is billing over and over and over again the wrong procedure code for certain things, the health plans notify AMA, who writes these books, who write up another book to let you know what exactly is involved in that procedure, because you're just getting one tiny little bit of information right here, and you're supposed to be able to code off of that. And sometimes it's just not enough information. So they do clinical examples in these books too, and they list out a complete description of procedures. They even give you a rationale that will go on for days, why we use this code, why we don't, what codes we would use alternately if something else was going on. So I get these old books. I don't ever get one for the same current year because they're super expensive, but like some of these older ones I can get from Amazon and ship to me less than $10, and then a lot of them are from really old books, but still it's helpful to get more rationale. Then I can write more information that's not included in some of these and add that to my notes so that y'all have them. I do make PDFs of all my CPT books. Sorry, I was letting a cat out. Of all my notes that will notify you which codes were on my exam, what codes I found in the clinical examples, and show you how to prep these books for the exam with all the information that I can verify is 100% correct, and to the best of my knowledge. I am human, so bear with me if there are mistakes. But I'm just trying my best to make sure that everybody can pass. I got just seeing everybody fail over and over and over again. There had to be a reason why their coding course wasn't working, or other coding courses weren't working. What was going on? There was a lot of misinformation about what you can and cannot write in the books. And I'm just trying to cut through all the red tape and show you exactly what you can have in the books, what will help in prepping for this exam. Because once you get in the office and you start coding and working 100%, nothing's going to be like any coding course at all. Nothing's going to be like the exam, every doctor's office codes a different way because of their signed contracts with the health plans, the medical groups, the laboratories, the hospitals, based off groups, based off contracts, based off all kinds of eonces that are written up in contracts, and there's policies and procedures on everything, and it's all going to be new to you no matter what. So none of this is going to help you once you get into the office. Once you get in the office, you're going to have to be trained. And then the best way I found is to go find, if you have a patient who came in today for a procedure that you didn't know, maybe a circumcision or something that you've not billed before, just go look up the codes in the EHR history and see how other people billed it before you, or look in your policies and procedure books. There's a lot of ways to help you once you get a job, but it's all going to be different no matter what anyway. So getting you past the CPC exam is my main goal so that everybody can find a job. And I have tips for that too. But the main thing is we got to get this book prepped because it will help you with the process of elimination and getting these tests and certification done. The exam is 150 questions, and you think 5.5 hours is enough time, but you need to do 30 questions every hour. So that gives you 120 seconds per question. And your 120 seconds starts as soon as you open up your answer booklet or you turn on your computer and click start for the test. So your time is ticking, and they don't give you enough time to read all the rationale or the question or the op note. And then they definitely do not give you enough time to go in and look up all the codes that are available as possible answers. There's not enough time. Just turning and getting to the right code is a challenge in itself. So I'm here to teach you how to do the process of elimination and get through this exam with as least amount of brain fatigue as possible so you can have a good sharp brain for the entire 150 question 5.5 hour test. You're going to need to know, I'm sorry, I don't know why it would be. I'm on really good internet. No, I really don't recommend any online billing or coding courses. None of that's going to help you pass the CPC exam. What will help you pass it is learning the process of elimination, learning how to do a word search based off descriptor words in these CPT codes, and being able to pick the right answer fast. And knowing where to hunt down information if you don't know it for anatomy or Hpcps, or to be able to write in all your guideline or regulatory information, like what does Medicare Part A, Part B pay for, Part D. Be sure and write all that before your E&M section in the front of the CPT book. Anything you need to know to memorize, you need to write it in the book, and you need to have it organized for the exam so you can find it right away. Different colors for different things so that not every word or definition is all one blurry color. You need to be able to find it right away. Coding courses just are not going to help you pass this exam. They really aren't. I haven't seen anything that's going to do that. They're too wordy. They are full of busy work to make you think that you're getting your money's worth by doing all this coding, by looking up things in the index and verifying in this tabular list. Nothing of that is going to be able to be done during the CPC exam. Printing out your guidelines and taking them with you, you're not going to have time to reference those. You're not even going to have time to even look up one of the guidelines to verify you have your information correct. What you need to do is move your guideline information to the particular codes in the books, to the codes where it's going to affect you. There's just not going to be any time. You think 120 seconds is enough time. It really isn't. There just is no time. Like for the external causes, I moved my guideline to there. Never the first diagnosis, and this is how you code, thank you, for external causes. If you have the information, the cause goes first, the intent, then the place, then the activity, and the status. That's a sequencing of events that you're going to do that particular code. The burns guideline, I moved it to the codes that affect burn. Right here, burns are coded 3rd degree first, then 2nd degree, and then 1st degree. Corrosion, if you have both, corrosion and fire flame burns, corrosion is always coded first. Even if it's a 1st degree corrosion burn and then you have a 3rd degree fire flame burn, then corrosion of that 1st degree goes first. Then you do the 3rd degree of the fire flame burn. How do you know what corrosion is? That's like battery acid, things like that. Even though it might have caught on fire, that kind of thing. Burns include electrical and heating appliances and stuff like that. They give you the information of what it includes. What it does not include is radiation, sunburn, those kinds of things. So be sure and know where your information is at. And if it's giving you all this stuff about please refer to this guideline, then go get that guideline, write you some sort of information up here about what that guideline says, because you are not going to have time to go flip to 1C 19D, then evaluate it, figure it out what it means in your head, and then answer the question. There's just not going to be any more time. Hey Jess, I'm just reviewing. What is the one in red? This one's the burns. Is this where you're at? The 3rd degree burn, the 2nd degree burn, sequencing. It's just my little chicken scratch for that. I hope it's not freezing some more. But Lan, love, mommy. You can't hear. I hope y'all can hear. Now I can turn off some of the... Do you help with the CBP? Yes, I have AAPC's CPB course. All of its exams and practice information. If there's anything in particular you want to know. Cardiology is becoming one of my favorites. I'm getting to know where I like it because I'm playing around with it enough to figure out what the differences are. A lot of things in cardiology are broke up as arterial or veins. So, hold on one second. I'm going to turn off the air conditioner. Maybe some of that background can cut down on all the noise in the background. Me too, Jess. I was busy today too. Cardiology I'm starting to really like, because cardiology seems to be pretty much mostly each thing is, especially the cabbages and things and implanting things, pacemakers and stuff, it's mostly arterial or venous. So you need to know, first off, where am I at and what veins or arteries are going to be messed with. Once you get that down, then you know which particular code you need to be under first. And then you can pick how many. Was it simple, complex? Was it 1 graft, 2 graft, 3 graft? what helps is I wrote E&M scenarios for cardiology based off time, and then I wrote another one based off MDM. I have the major Hpcps codes, the major J codes, injections that might have been used, the category 1 codes that might be used. I listed out most of the procedures in their most intensity, because some things get done together, and to know which one you code first, you code the highest intensity thing first to the easiest thing last. So that helps. Also, writing in all your prefixes, suffixes, some of your major ICD10s, adding to the anatomy when they forget to write it in. They've drawn it in, but they didn't label it. So I do all that kind of information too. Some old diagnoses that are kind of hard to find. The directions of the blood flow through the heart, they most definitely always ask. Some of the common definitions. And then, like here, they didn't even add, they drew all this stuff, but they didn't describe what it is. So I just wrote it in. Prefixes, suffixes. This really helps out with your anatomy in all these sections if you go and do that. Common modifiers, common Hpcps codes, all that kind of information. If you need any of this, I have PDF printouts, which are in the link in the bio. Once the live is finished, you can find that information. But you can get page by page and see what I've been doing. Medicine is the last section I did this year in the 2021 version of the book. So it's the most up to date with most information in it, because I was learning as we went along. When I started out doing E&M, and then I went to anesthesia, but medicine was the last one that I finished, and it's got everything we learned along the way this year as far as what to write, how to label things, all the differences, and it's got added more examples in it because I was starting to get those CPT changing books, those books that are listed down here, the CPT assistant. I started getting all those in and adding in those examples down here too. So even if you just get one section that you print out, you can follow what I've done and make it into the other sections quite well. Next year for 2022, I'm typing it out, so it won't be my scratchy handwriting that you got to figure out. Hopefully that will help. I'm just going to get up some CPT questions. I mean, even if one question is this long, you really think you're going to have 150 minutes, to get through 150 questions through a scenario like this, and you're going to take and decide and mull over what they're saying. It's really not going to happen. The time goes by so incredibly fast on these. It's really important that you learn the process of elimination so that you can move through these questions super fast. I'm just moving on to the ones we have not done yet. And let me see, I'm getting messages here. Let's see what's going on. I hope y'all can hear and you can see. I got a 70 in cardiology. I'm hoping for better this time. Yay, beast. That's awful. It's pretty good. That's pretty good score. But lab and path and medicine are always one of the most challenging sections because all the codes are out of sequence, especially the ones that are in sequence are pushed out of sequence because there's so many out of sequence ones once they get placed in there. I don't know. You can get really lost in lab and path for sure, trying to find codes. And a lot of those sections are just guesses. So if you can build up every other sections to the 80s, you'll be in a lot better standing if you do a little worse in medicine and lab and path. Aw, all right. You've got a beast of a husband. That's cool. I like his name. Sometimes you're on your sister's account too, so that's cute. You're just like, wherever I'm at, somebody give me a damn phone. I got to go live. I love your dedication. You're awesome. I'm really going to miss you when you pass your exam and you're not in my lives anymore. Somebody says, I have a question. Okay, well, let's see. What is it? Oh, oh, it helps. Okay, that's it. Nothing important. Nothing important. Okay, let me get this first question adjusted so we don't see the question and the answer in the same area. This one looks like it's going to be E&M-ish. Ooh, she remembers some questions that were on her CPC exam. Remember, this is some of the questions on the CPC. Where do you think I can find that? Okay. Pharynx, the skilled Medicare program, skilled nursing facilities. Yeah. So one of the things you should have in the very front of your CPT book is what part of Medicare, Part A, B, C, D, would pay for skilled nursing services? You have 90 seconds now that you've read that question. What would the answer be? Yep, Medicare. Some people are saying Medicare Part A. Some are saying B. I gotta find my old book. I don't do coding and billing every day because I am a medical auditor. But I know I wrote all that information down for the exam. Okay, wrong old book. Oh, wrong old book. Where's my other one? Right here. So obviously I didn't write this for anybody else to see but me, but you can see how all one color looks like crap. Be sure and separate these out into different colors so you can read it super easy. Medicare Part A does skilled nursing is what I'm seeing right there. Skilled nursing. So I do have them all listed here and what they each pay for. Just because, you might know this in your head right now, but when I get down to take a test, I can forget what my name and date of birth is. I'm like a deer in headlights. Even though I'm a medical auditor with 20 years experience in my head, just a timed, under pressure, I really need this kind of exam can be very challenging for you. I'm just answering a question there. Good job, good job. It's his rapper name, aww. My oldest son, it's not a name that he would ever go by in public, but I call him Pookie. So, if I had him a TikTok, I'd say it was Pookie something. Pookie 1991. And then he might have some rapper name, and I'd be all, that's my Pookie 1991. And he's all trying to be the beast. They're so funny. Yeah, we've gone over some more stuff in cardiology. There's that one cardiology one I wanted to make sure you know of, Jess, that came up on one of somebody's last exam. It was a practice test question. It wasn't a verified cardiology question from that section, but just to be sure it doesn't show up on your exam, be sure. I mean, there's stuff like this is just a laser. It's things like that make the difference. This is using radio frequency when they're doing that procedure. Little things like that could mean a big difference, knowing what to do. I use this external cause diagnosis code with that CPT code. A lot of things are super cool like that if the information that I have available that goes along with it, if you have the time to ration out the question. It's tough because you're under pressure and you're taking the test so fast to stop and realize what's going on. I have the cardiology guideline tips at the end of the section right here just because I had more white space about cardiology. There's not a whole lot of stuff. This one's actually just for musculoskeletal. But things like if something is documented by the doctor saying it's involving a joint, you actually diagnose the bone, not the joint, if you've ever noticed that. Especially like in osteoarthritis, you don't say it's in some joint, you say it's in the elbow or whatever bone is infected. It's kind of interesting information. But that cardiology thing right here is code 33249. So be sure you know that the question stated in this order: dual chamber, transvenous, implantable defibrillator. That's what it said in the question in that order, and that's where that thing is. And be sure, because I bet they made you confused, that you know that all cardiology codes from 330206, not 33206, 33249, all those codes already have radiology in them. Don't put some 77 something or another code in with them, because these already have all your fluoroscope, radiology, it's all included. Okay, all these back. So all the way to 206. So that's probably where you got your 70%, was thinking that you needed to add the fluoroscope. And they don't tell you, this doesn't say anything about having fluoroscope in it. But unless you have that information from networking with other people or some other way, it's really hard to tell. Some things are just battery replacement. That's what a pulse generator is. Some of them are dual or single leads. Those are the major things that are on them. Dual is not the same thing as multiple, so be sure you know the difference. So right here, if we were doing this CPC question, what I recommend is running straight to the answer first. You're going to look at the answers numerically. Which two of these are super close together? And that's how I do the process of elimination. Hi, Miss Ashford. Good to see you. Hi, Diana. Hey, Steffi. Easy thing to remember is Medicare A is inpatient, Medicare B is outpatient. Hopefully that will help this person who was asking the question about skilled nursing services. So that's kind of like in your home, right? So knowing that kind of information. Just giving her more information. What you said, Jess. All right. Hello, Lady K. So, numerically, when I look at this, I would get rid of A because the 5-3 is not close to anything else. And I'd get rid of the 2-1 because the 2-1 isn't close to anything else. I like these two because they're only one code away from each other numerically. Not that I may have to go back and look at these, but if I'm trying to save time, AAPC does have a pattern, 95%, I don't know, 92% of the time, where two answers will be just giveaways. They're just crap. And then two answers are going to be side by side, super close, and then they're going to word the questions psychologically to confuse you, to make you think it's one or the other. So I take human nature out of these test questions, and I don't let you go about answering them in a normal human pattern. We're going to go straight to the answers. We're going to eliminate two answers if we can. Keep two just based off the numbers, not really using any other logic than numerical order. And then I'm going to run to both of those codes, the 3-3 and the 3-4. I'm going to see what the difference is between those two codes first, before I even look up the question. Don't even know what the question is. So 99233. I'll go over here. Sorry, my camera and stuff shakes so much. My son says I did this all backwards and all wrong. It's all archaic. I should have it on some sort of computer. I don't know. They do all this Discord and fancy Zoomy stuff, and yeah, I'm doing this all wrong, I'm sure, but I'm just trying to help. 99233. 233. So we're under subsequent hospital care. 3-3 is DDH, detailed, high, and we're using 35 minutes. 34 is either detailed, or comp, low, straightforward, and they used 40 minutes. One of them is under subsequent hospital care. The other one is going to be under the heading of observation inpatient care. So we didn't even need to know the detailed, high, and all that stuff. All we need to know is look for the key term subsequent, or visiting the patient on the second day. They were admitted yesterday and blah, blah, blah. We're just visiting them. They're not being discharged. They're just there. You're getting evaluated. This one, the 3-4, will be discharged. We saw them. We've been taking care of them. Straightforward makes me think that they had something acute wrong with them, appendix, something ruptured, I don't know. Gallbladder, removed it, send you home. Straightforward, low complexity, and I'm discharging you, sending you home. So either the patient in the question's getting discharged, or they're just being seen while they're staying in the hospital. So we're going to go look for those key terms, discharge or subsequent. So we're going to skim from the bottom of the question, the very last words, and we're going to see what are they asking. So they're asking for an E&M management for the following day. That makes me think that they're doing the subsequent hospital care because of the way they worded it. It doesn't say anything about discharged. I do see they did a colonoscopy. Read backwards, but we're really not reading. We're just skimming. So they were admitted the following day. Tells them the results. They do have gallstones, and they recommended removal. They haven't even done squat to the patient. They haven't removed their gallbladder. They haven't fixed their issues. They're just being told of their test results, and that's it. So we know for a fact it's going to be that 33, and we can pick C, and we can move on with our exam. You need to be able to do this obviously a whole lot faster than what I did, but you're getting the premise right here. Let me scoot up this one real quick so you can't see the question and the answer at the same time. Let's see, just tomorrow I have a doctor's appointment an hour away. I have to leave here 1:30, so that's 4:30 your time? Yeah. 4:30 to be there. I have to be there at 3, so it's an hour away. And then I don't know how long to see the doctor and then back home. So the afternoon, it might be kind of late. Like I should be home by 5:30 or 6 my time, but that's still going to be 8 your time unless you're off or have a lunchtime or can do something in the morning. So just let me know about that. Anyway, for this one, I still don't have it separated out enough, do I? Stop looking. Don't look. It's 20. Well, okay, to get rid of, I really don't like D because the 3-5 is weird. I've got an 8-4 and an 8-4, and then I have a 19 and a 19. So I've got, this is 1 and 2 scenarios. So I got 2 scenarios. So I would go to both those codes, see what the differences are, see if I need to code them together or separate or what's going on here. So 99219, 99219. 99219, we don't need to look here. We need to look at the heading. We're under observation care. Then the 99284 is under what heading? Emergency room. Okay, so we need to know whether the patient is in for observation or if they are in the ER. You definitely wouldn't code those two together. Like, you know, you're either in the ER being treated or you're been admitted for 48-hour observation. So we can immediately get rid of A, right? So we know it's going to be one of the two. Let's see what the question is. Select the appropriate code for the visit. So we're going to skim up, and it says they're in the ER. And place the patient under observation right there. You see the key term? Observation, to make sure their asthma or whatever is okay. So we're definitely going to pick 99219. Where did it go? 9219 for the observation, because the other one is under emergency room visit, which doesn't have anything to do with why we're here. They were seen in the ER, but you're not going to bill for an ER visit because you're going to keep the patient in the hallways, or if you happen to have an observation wing of the ER, you're going to monitor them, have pulmonology come down probably and evaluate and make sure that their breathing treatments that they're getting in the ER are really resolving their issue and that they're going to be okay. So we're definitely going to pick B and move on to our next test question. Why are you freezing up? Don't know why it's freezing. Thanks for the share of the live video. I won't get off work till 4:30, so that is 7:30 my time. I'll definitely be home by then if you feel up to doing a one-on-one eval or overview of my book before your test on Saturday. Everybody wish Jess very much good luck, please, because we want her to so pass this time for sure, although I'm going to miss her. Let me get this one out of the way real quick. Yes, Diana, I hope she does. She's so got this time. Here is my little cheat sheet I write at the end of my evaluation and management. Because Appendix A is a pain in the butt to get to, and I hate tabbing the book because, as you can see, you're just going to go from CPT codes and you're just going to be looking numerically through this book for numbers. You're not going to index anything. You're not going to look up anything. You're just running to numbers. So I recommend not tabbing anything. But I like having the modifiers at the end of the red section because it's easy to find. It's in the front of the book. And then we refer to these all the time. The ones that they love to use during the CPC exam is increased procedure. So my handwriting, plus I've ruined some of it. Professional component. Discontinued versus staged. Of course, bilateral and multiple. Where's 20? Is it 20? What's the one for the E&M code? I always have it up here because I like to have it up here. Now, where's that E&M chart that we have? Right here. The E&M modifier 25, they use a whole bunch because a patient may come in for sutures but also get their well child exam. So you'll use that modifier 25. That's super handy to use. Yep. Ooh, we got an anesthesia one is going to be our next one. Let me get this moved. I was talking to somebody today about anesthesia just kicked their butt. Oh my gosh, she got like, I don't know, 10% score on anesthesia. And I bet it was because of the anesthesia modifiers. They don't teach you in these courses about the modifiers. So if your test answers have some really weird modifiers like QX or whatever, be sure to look in your Hpcps book. Your Hpcps book has a whole list of all the CPT modifiers, including Category 2 modifiers, Hpcps modifiers. This is all on the front cover. There's even more modifiers from AA all the way to MB here. Tons of modifiers that may or may not have anything to do with Hpcps at all. But the back cover of this Hpcps book has all the anesthesia modifiers here. You need to move this box to the beginning section. It's a green page on your anesthesia guidelines that happen right before your anesthesia codes. You need to move all those there. The ones that they really like to use during the exam is QS, QX, QY, QZ, for sure. Be sure you know your P modifiers, P1 through P6. P1 is somebody that needed anesthesia, but they were healthy otherwise, like they were in a car wreck and you need to manipulate a bone to get it back into place. And you put them under anesthesia. P3 is like, yeah, they were in a car wreck. We need to put them under anesthesia to fix this bone, but they also have CKD and hypertension and morbidly obese, and they're going to have to be monitored. They're pretty sick. Down to P6 is if we're just harvesting organs, but we have them under anesthesia for that. But you need to know all of these, so be sure you have these. They've got ambulatory modifiers. The back cover even has even more. Tons of modifiers. X4. There's just a lot of information there. But the main ones you're going to need is those anesthesia ones for this section. Anesthesia, I wrote right here, and it's really, I had to cram, but it's there in case I need it. Be sure you know the 4 types of anesthesia: general, regional, monitored, and local. Monitored is called MAC. There's a modifier for that too. Regional is spinal taps, where local is to numb each finger. Tomorrow I'm going to go see about my fingers that are no longer functioning since I fell at Disneyland in July. I'm just now getting in with ortho. Those 2 will not bend anymore, so I'll have to have some anesthesia to reattach those tendons in the back probably. So hopefully they can do just a block here and fix that mess by reattaching. Hopefully I don't have to go general. That would suck. Each unit equals 15 minutes, and your guideline for anesthesia is if they are less than 1 year old and they are greater than 70, you need to always add the CPT code 99100 as a secondary code to anesthesia to note that they are of a higher risk. So if you know your modifiers, these GSs and crap, you know this one, then you'll be way better off than knowing just 10% of the anesthesia. All the pink codes are the ones that were on my exam. They really thoroughly cover anesthesia, let me tell you, for sure. On the exam, let's look at a test question example. So if we were just looking at this just based off of numerically, come on, focus. Come on, there we go, maybe a little bit more. Which 2 sets would we like here? Which one would we get rid of? You can see that specialty right there. We need to know if we need to use it, right? Also, the 6 is not like the others, so I would get rid of that one. Neither is the 70, so I bet it's between this one and that one, right? 70's not like that one, so I'd pick B and C. Good job, Beast. I'm the real slim Katie. That is so cute. We got another gangster in the house. So we're going to look up real quick. We are doing a 6-month-old who will fit that guideline, being less than 1 year old. So we know we need to add that. So if you're super smart, knowing that information And knowing how AAPC takes these tests, God, that's so frustrating when they won't zoom in properly. So if you know that guideline, and you know they like to use codes that are super close to each other, you wouldn't even need to look up anything on this one. You know you have to use that code. You know this one is used twice. I would pick C and move on without even looking up anything else other than the kid's age. 00172, if you wanted to look. Oops, I just ripped my book. Oh no. 00172 right here is a cleft palate, and I bet that's what the question is leading to. Look, cleft palate right there, if you really wanted to look. But, you know, if you know and you're calm and you think out the numbers rationally, numerically first, then you think of any tips or hints that you might have for anesthesia, then look at the codes again. You can sometimes do these questions without even reading anything on the question, except for looking up a number right there. We looked up 6 months old. That was it. I hope this is helpful and I'm making it sound rational to you. If this example I have is a 79-year-old, what are you going to do there? You know you're going to have that code as a secondary in the answer, right? Yep. And she had some ventral peritoneal shunt put in. They used that anesthesia. She was healthy otherwise. Not quite sure how healthy a 79-year-old person is. She had no systemic diseases, no hypertension, no other issues. Great. P1, okay, if you say so. That's great. But that's exactly what they had on the exam, so that's okay. Knowing some of your anatomy along with this, that the anterior trunk means the front part of your chest, your breastbone area. If it said posterior trunk, you'd be at your back spinal area. So some of that stuff is, I like to write in the AKAs on this. I had an example of a mastectomy. They did a reconstruction with the flap, and they used the 00402 code. Up here, I use that one, and see they use the muscle flap. Check out the message somebody sent. Hello, Miss Mel KB. We're just going over some P for P or CPC questions. Gosh, why am I thinking P for P today? I was doing my job today, which is a medical auditor. Good gracious. And I like to do Hpcps, HEDIS, and CHAPS audits are my favorites to do. But any kind of health plan, medical group, doctor's office, any kind of audit that they're doing, I can help out with any kind of audit process and make sure they pass, or come in and be a third party for that medical group so that they can perform their audit. A lot of times you can't audit yourself. So, and you can't have a member of the health team or health insurance group come in and audit you either, because they might be biased in setting up contracts and how much groups get paid. So you need a third party to come in and be neutral. So I like doing those too. Those are fun. And I really just like going in and making sure that doctors groups or medical groups are doing everything appropriately. You know, their refrigerator logs are appropriate for their vaccines, or they don't have their lunch, stored in there. I've been in offices where the coffee pot is up on top of charts. You never know. You never know. Or they never make any cash deposits. Why is that? What's the deal? What are they doing? Squirreling them? I found one office who stapled every dollar they got to the patient's chart. They didn't know that they needed to actually physically put that money in the bank, and they literally had $5 copays stapled to the charts for the office visit for that day. Each office visit had a piece of paper. Not lying. It's fun. I love going in there and thinking, where did y'all come up with this from? That sounds fun. We just did that one with the trans flap. This is that patient, the 50-year-old who had mastectomy, and she ended up with a tram flap. And that was the answer, the O2. And you know what would be nice is, because I don't have it written in here. Oh. Anytime they give a procedure a specific word, like AKA, I like to add that to my notes, because some procedures are called other things, and this is called a tram flap. So if we ever see it again in a question, that AKA word is there, because it's not really listed there as called that. I mean, it's called a flap, but it's muscle flap, but did they even say it was TRAM? No? Okay. So I like that. I'll add that to next year's notes. Miss Mel, I hope you are. Miss Mel is working towards her CPC or something, and I can help show how to do the process of elimination here. I'm just trying to get rid of the questions and the answers so that they're separate, so we can evaluate them numerically first. Is the process of elimination that I found that works really well with AAPC. They commonly have two answers that are super close and then two throwaways. For this one, I'm just evaluating numerically. So this one, the 00 is off and the 04 is off. These two that start with the 02 are super close, right? Then one of them's got the 06 and one of them's got the 7. Well, 26, and one of them's got 27. I wouldn't look up the first code because it's the same in both, and these two are the same in both. The only two codes I would look up is the middle code to see what the difference is. First, get some key terms from their descriptors, and then I'm going to skim the question for the answer. 62326. 623. This is one of the sections you wanted to know about, Jess, too. We're in the 6,000s here. 623. I am super slow at going through this book. Y'all need to be sure and get super fast. One thing to note is to get in a habit of looking here for the numbers instead of going through each column looking for the number that you're looking at. That will slow you down. If you look here and you can recognize if your number's on this page or not. We're looking for 623. No, we went too far. That will help you better than skimming each page. It'll save you a half a second or so every time you're looking. 62327. So we're going to be in this area. So 623, 26 and 27. There's 26 and 27. 26 is a parent code. 27 is a child code. 27 is with imaging. The other one is without imaging. It's all we need to know. I don't need to know what it's doing, what they're doing, what's going on. All I need to know is what's the question, performed. I just need to know if they are using any anesthesia or not. I mean, not anesthesia, but imaging on this, right? So they're doing a knee replacement, just skimming, insert, fusion, management, done. Nope. No thing about radiology there, so I would pick C and move on. It doesn't say that they sent them up to get radiology. Doesn't say anything about it. Don't see anything with imaging, so I would pick see and move on. Most definitely. Let me know if that does not make sense. Be sure to know in your appendix right here, some of your guidelines, they do have the P's here, but they also have your eyes and your fingers and toes. Be sure you know those two. And I like these two. If the patient's not being compliant, there's some neat information there. I've not ever seen that used on the CPC exam, but I really like those two. I would love to use those on patients just because I'm an auditor. That sounds so much fun. Hold on, somebody's at the door. I'll be right back.
Mommy, don't you ever wonder how peaceful our flipping planet would be without the internet? This is how peaceful it would be.
You think the internet causes that?
Yes, cause
Maybe we had wars when there was just Indians and tribes here and settlers. The internet did not cause our interplanet warrior thing, or whatever you want to call it. My kid's like, just think how what was his wording? How peaceful the planet would be without the internet. I'm like, we've never been really peaceful people. We're just humans that love to fight over every little thing. I like to share information and help people. So I'm different. But I don't think the internet causes all of our unpeace. Okay, come on, Lappy Top. Talk to me. We got to get some more answers up. Hello, user 845. I'm going to push this out of the way. We still got 7 on. All right, let me know if you have any CPT codes or questions about coding related that you've run across. You don't understand why the answer is one way or the other. And I cannot get this laptop to do anything right now. Oh yeah, that's right. I have the picture on, not the pointer on. Let's see if that'll help. No, you're just not going to respond to anything, huh? Oh my goodness. Maybe our planet would be better without the internet. I don't know what's going on with my Lappy Top right now, but I can't get it to move to another question. It did not like me getting up and seeing who was here. Oh man, you want to really tackle something hard. We can tackle this lab and path area for sure. What guideline questions do you think they will ask? Yeah, that one's a good question. And I have an idea on what they're going to ask. Let me get my ICD10 book out. I have them flagged. And I'm going to make for 2022 a list of my top 10s that they always ask. And they're going to be on a more reasonable area than all this nightmarish stuff that we have going on here with these guidelines. So I really think they get way crazy wordy with all this stuff. And it's impossible to learn it all, too. It takes a long time to know these and to know a lot of things. And there's a lot of stuff that you just can't learn in the time frame for the exam. And you just need to let it go. Like MOHS, MOHS, I just didn't want to learn them because they had their own set of guidelines that went opposite from this, and other things that, I just never took the time to learn. And I still passed the exam just fine, not knowing every single subject that I knew was going to be on that exam. Medicine and lab and path are difficult. If you can get 50% in those areas, wonderful. Just get your other areas like anesthesia and things that we know 100% that are way easier to spend your time on to get to know those areas, because you could spend a lot of time in lab and path and medicine areas, but that time won't be spent wisely because of the time it takes to learn those areas. But you could spend a fourth of that time and bone up on other areas in the CPT book that will benefit those areas to bring up the areas that are going to be lower in, if that makes any sense. But guidelines that they are definitely going to ask you about. If a patient is here or in the ER for an acute condition and a chronic condition at the same time, like thyroiditis, some conditions can be chronic and lifelong, and they run along just fine. But when they have an acute problem that needs to be addressed because they're having some sort of acute crisis, they can be diagnosed with both. So just be sure you know your sequencing order on those, and acute will go first, chronic will be your secondary code. Be sure you know inpatients. The diagnoses are per admission, but outpatient services like doctor's visits and stuff are per date of service. It's obvious guideline. It's not nothing hard, but the wording is interesting. So sometimes they have this weird question that's worded kind of weird. Just know that inpatient is per admission for diagnoses. I should have equals diagnosis there. And then I should have outpatient provider equals data service equals diagnosis, Just something to make sure you know about that question. They do ask that weird question about who can diagnose patients with certain things, like who can do the BMI. Even medical assistants can do the BMI, or the EHR is set up to do it by itself. It's not nothing that the doctor actually goes in and says your BMI is 29.6. The MA may put in the height and the weight, and the computer figures it out itself. It's in the chart. You know you can code it, but it's not a code or verbiage that the doctor wrote in its summary or plan. Does that make sense? So they have guidelines for that kind of stuff that says, okay, for certain things, you can use that as a diagnosis. It's not going to be primary, but you can add it to your list that they have a BMI of 29.9, and there's an actual specific diagnosis code down to the 5th code or whatever that says they're 29.4 on the BMI scale. And it's okay if the doctor doesn't say it and an MA keyed it in and then the EHR figured out that number. But they do have certain guidelines about MDs, DOs. They're the ones that must diagnose pressure ulcers, strokes, things like that. You can't let a computer or something like that independently tell you to diagnose it. So that's all that statement is using or working with right there. On your HIV and AIDS, you know that HIV is the only condition that will code until the patient dies. And be sure you know who wrote that law. That's per the CDC from 2014. It's one of those regulatory words or guidelines that I like to write in the front of my CPT book before the E&M section. It states who made the law and what year. Just one of those weird ones that they sometimes ask. So that's also in my notes right there under the HIV area, that's per the CDC from 2014 law. They have certain scenarios whether HIV or AIDS is diagnosed first or secondary. If they have symptoms or they don't have symptoms or they do have symptoms, what you code first, what you code second. So if they're unsymptomatic and they come into the ER for a fractured ankle, you're going to code that fractured ankle first and any other conditions they might have, and then that Z21. Now, if they have symptoms of HIV right now, you're still going to code that fractured leg and any issues it might have had, like diabetes or anything else that might be related. Then you'll do your B20, and then any HIV symptoms that they're having or related illnesses will be third and fourth. Oh, some of those guidelines are kind of crazy. And then they have the pregnancy one that you'll be doing, and then those will be the second and third guidelines. And then again, they have it if they have no symptoms. They go back and forth, and they get a little crazy. It's just one question, but try to keep in mind that if fractured legs are always going to be coded, even if it's pregnancy. If they're 20 weeks pregnant and they fractured their leg, you're still going to code that fractured leg first. Kind of easy to remember when you look at it that way, because you need to code based on what's being done for that service visit that day. Yes, the other stuff that's important will be there, but usually it's secondary. Knowing your sepsis, it's going to be on there, your guidelines, or a sequencing issue that you need to code for ICD10. I have a one-sheet page for sepsis, but I also have the guidelines written out for sepsis. And it changes depending on whether they have an organ failure that goes along with the sepsis or if it's just an infection. They do have a chart here that tries to help out, showing you which one to code first, which one to code second. But it does change based on whether they have organ failure or not. That's the key part in that one, knowing whether to code it one way or another. Malignancy, You're definitely going to have some of those guidelines in here, and it's mostly going to be pertaining to the treatment of cancer. So if they're coming to outpatient services for chemotherapy, immunotherapy, or radiation, you know you're going to code the Z51 code first. And I know Z codes are never supposed to be coded first, but they do in this example. So another thing is if they have metastasized cancer and they have brain cancer that metastasized down to their spinal column. So they're going to go see a musculoskeletal physician because of the spine cancer that is secondary due to their primary cancer in the brain, and they're seeing the spine specialist. You're actually going to code that secondary code cancer site first, then you'll do their primary malignancy second. But if they're in seeing a neurologist for their brain cancer, which is their primary cancer, you'll code the primary malignancy first. You'll also code their secondary, even though they're not being seen for that secondary that day. If they have anemia, things can flip around, and or dehydration. It depends on how they got the anemia. If the anemia is associated with the malignancy, you're going to code the malignancy first and then the anemia. Now, if their anemia is associated with the chemotherapy or immunotherapy, you're going to code the anemia first, then the neoplasm, and then there's going to be a T45 code that you need to code after it. If their anemia is due to radiation therapy, you're going to code the anemia, the neoplasm, primary, secondary, whatever, and then there's a Y code for that one. You're definitely going to have some of these on your CPC exam. If their dehydration is due to a malignancy, it's going to be different than the anemia due to malignancy. Here you did malignancy first and anemia. Well, if their dehydration is due to their anemia, malignancy, then you do dehydration first and do your malignancy next. Don't know why. I wish it was consistent. But you need to know all those. Every scenario I just said, you need to know those for the exam. And I hope I'm explaining them okay for you. Let me know if you got questions or concerns. Sequencing malignancies, I went over that. Sequencing pregnancy in a pregnant person, you're going to do the pregnant state and then the malignancy. If they're having complications and they're being seen for that complication due to their neoplasm, like they get fractures due to the cancer, they have bone cancer and they're getting fractures, you're going to code that complication first and then the neoplasms. Good. I'm glad it's helpful. Personal history of a neoplasm means that they are in remission. There is no cancer left in their body. They're totally done with any type of treatments, and they're no longer even on an oral pill to prevent cancer of some sort. So only use that in real life once they're completely done and they're over anything like that. I don't believe there was any malignancy issues due to the organ transplant. I don't remember that ever being on anybody's malignancy neoplasm associated with an organ transplant. No noticed anything like that on there. Underdosing and overdosing will definitely be on your CPC exam. The guidelines, pretty basically the same. you're going to end up with the T85 code first. If they didn't take enough of their medicine, or if they took too much of their medicine, it's still going to be in the same order. You're going to have a T85 first, and then the T38 next, because you're going to list out the medication. You're going to list out, what external cause happened due to this overdosing and underdosing. It'll be in that range. You'll have to pick out the last digit. And then over here, the medicine. And then you'll give their underlying diseases. Most of the time it's diabetes during the CPC exam. And then any associated complication like they had nausea, vomiting, rashes, went on to ketoacidosis, too much stuff in their urine, and they had to have some little dialysis to get over that. Something like that. Those are definitely going to be on there. There's also going to be one where they took a medicine as prescribed by a physician appropriately, and they still had a reaction to the medication. That guideline is usually always in there. Let me see if I can find it real quick. And they skip it. I don't know why it's so far away from the other ones when we've already got underdosing and overdosing. But page Z26, we've got another scenario where they were given a medication and they had adverse reaction to it. First, you're going to diagnose, which is different than the underdosing and overdosing, where you finally put the side effect down or the nature of the problem, like the ketoacidosis was the last diagnosis over there. Well, if they got ketoacidosis due to the prescription went awry and messed up their kidneys, you would put their adverse reaction right here. Most of the time on the CPC exam, they are talking about like Darvocet or some sort of pain med that they got, and they got nausea and vomiting, and they just couldn't take it. It got real dizzy with it. So you're going to diagnose the side effect first, and then you're going to diagnose that T36 through T50, the name of the medication that they had a reaction to. If they were poisoned by a medicine, like I get anaphylactic shock with certain medications, my heart can stop and I can turn purple all over. These big, huge whelps, and they're super itchy, but they're huge. If you can see them, I start at the head and I go all the way down to the chest area, tummy, and then the legs are usually the last part that turns whelpy. But I can get something like that really quick, and you're going to switch. You're going to do the medication first. The manifestation was anaphylactic shock, whether it was drug or alcohol poisoning or not, and then you'll do whether I'm abusing or dependent on a certain one. So a lot of people can get alcohol poisoning in this scenario, and they just drank too much of the alcohol or tobacco abusing. I've even seen cannabis poisoning where they get super nausea and vomiting, and they can't stop spinning, and it's just because they hit the bong way too rough that night and got way too much stuff. So they got actual cannabis poisoning. And then what happened? Nausea, vomiting. What drug was it? Cannabis. And was it abuse or dependence or recreational? So that's the order of the coding guidelines for those. And those are some of the scenarios you might see. I think they have like 7 versions of the CPC exam, and each one can be a little different from the other one. But mainly, these are the particular ones that you'll always have. Let me see, is there anything here? Pain due to a device or implantation. I mean, you're just going to say the site of the pain and then the G89 code for that. Been seeing a few more of those because of those spinal implantation devices that they do for chronic low back pain and stuff. They're starting to add those scenarios in on the CPC exam, but it's not too hard. It does switch over here on the other side where you do the G89 first. If they're being implanted for the neurostimulator, you'll do the G89 whatever, because that's going to do like cervical, lumbar, sacral, and then the underlying cause, the pain. But if they come back later with pain due to the implantation of whatever device, you'll do the side of the pain and then the G code. But if the reason why they're being admitted is here, then you'll do it in reverse. Such a pain in the butt. Be sure you know about blindness being both eyes, or if there's just one eye, that kind of thing. I've seen that once or twice on the exam. What have I got over here? The order may be different due to the reason for the admission on hypertensive heart disease or hypertensive chronic kidney disease on patients. So it depends. If they're in for renal failure, you're going to code in this scenario first, which is their hypertension and then their kidney disease and then their renal failure. They have another scenario up here with the patient has heart failure. Heart failure is under the I-50 code. So the difference between the hypertensive heart disease and heart failure, be sure you know the I-22, the I-12, and I-50. The three differences in those three types of diagnoses will affect the order of the coding. Usually the eyes are first in many. It just could be different if it's just heart failure. So if they say something about heart failure, you'll do the I-11 code first and then heart failure second. But the other ones are going to be the I-22 or the I-12, and then the kidney disease is secondary, and then renal failure last. But in heart failure, you do your hypertensive and then your heart failure, because these don't have any renal damage right there. These do. But usually it's in the same scenario, I, N, and then your CKD. They have this lovely chart here, but you don't have time because that doesn't even say heart failure. So it's just too much. I can't follow what the heck they're saying over here anyway. So I split it up into just 3 scenarios. Heart failure will be secondary due to their I-11. The other scenarios are their renal failures, but always the I codes go first, then the N codes, and then the CKD. Let's see. This question is always on the exam, for sure, 100%. I only got 6 of you left now, but everybody knows this is going to be on there. NSTEMI evolves to STEMI, and then STEMI converts to STEMI. The secondary question they've started putting on these exams is this one right down here. So if you see something that says AMI, the answer is going to be this one, non-transmural. On these, it's super easy because we know convert and evolve always equals STEMI. So no matter what the question is, if it says evolves and converts, you know the answer is going to be this. But if they start out the question with AMI, that word is going to be your answer of that question. When you're going through A, B, C, or D, it'll say that. Pick that one, because it'll have the STEMI as one of the answers. So that particular one, most definitely. Pressure ulcers, be sure you know your stages of pressure ulcers. Right here. Get that. Stage 1 is just a sore, nothing's open at all. Stage 2 is skin break. It is open. Sore 3, stage 3, is it gets worse and extends to the tissue beneath the skin, and it actually forms that crater. 4 goes all the way down to the muscle, to the bone. You can see the bone underneath it, and they're actually putting on these machines that suck out all the bad juice out of them. Usually, just know your stages, and you always code your worst stage first, always, for sure. Kidney disease. You know, there's mild, moderate, and severe. And you know your code to severe. I think somebody's at the door again. We'll see. You only code 1 stage per person per visit. They can't have both, mild or chronic. What are you doing, Charlie? Don't wear a hat in the house. It's disrespectful. Wearing a baseball cap. Not under my southern house. I know I live in Arizona, but not in my house. Screen went black. Oh no, don't do that. Are we still there? Hey, Diana. Good. All right, and I hate this chapter in pregnancy. I absolutely hate it. You know that, and there's going to be a question. One of their questions is this question right here. Chapter 15 codes are sequencing prior over all other chapters. That's the answer. When you see it, it's be worded just like that. That's on page G19. But the very next section that we go over in pregnancy says that you'll code, let's say if they have a fracture of the ankle, you know, you're always going to be doing the fracture first, and then you'll do the OB. Oh yeah, they're pregnant, by the way, but just because they, you know, chop their finger off while slicing tomatoes or something and they go to the ER, that has nothing to do with their pregnancy. It usually doesn't affect the baby at all, besides the stress that the mom's under for that particular second or day. But you will code the injury code first before you do the pregnancy. If an OB has twin deliveries, first baby is born vaginally, second baby refuses to come out, and then go do a C-section. The order of sequencing for billing for that visit is going to be the C-section baby first, then the vaginal baby. You always code by the highest degree of difficulty. Same thing in cardiac procedures, same thing in skin tag, removals, cyst, flaps, burns, anything at all. If you are removing a cyst and 30 skin tags, the cyst is going to have probably a layered suture or layered packing of some sort. So you're going to code the lesion removal or whatever first before you do skin tags or shave biopsies or punch biopsies. So knowing that, keep that in mind. for sure, for all your guidelines there. Know what high-risk pregnancy is, because that may be one of their ABC questions. If you're over 35, younger than 16, if you had fertility issues at all or ever had any preterm labor or lost any babies beforehand, then you're considered high risk. That's it. That's it on babies, pretty much. Know your globals, babies. Moms' postpartum visits are usually, the 6 weeks to 8 weeks. It's all global, that kind of stuff. In the absence of documentation, if your documentation says patient seen today for immunization update, and the doctor ordered a tetanus and a hepatitis A, that's all you have. You don't know if they're a new patient, established. There's nothing in the chart, nowhere you can find out whether they've been seen before or not, and that's all you've got. Then you're going to code them established. If you have any kind of visit of any sort, and it does not state any degree of level of difficulty for any procedure, but you know the procedure was done, you just don't know if it's with this or without this or whatever, but you know a particular procedure was done. In the absence of documentation, always low code it. Whatever the lowest code for that known procedure is, code it. Don't do any difficulty with it at all. And always make it an established patient, not a new patient code. Where are we at? Let's see. We do not usually document any symptoms. You really needed a definitive diagnosis. Some exclusions to that are in the ER. If you need to rule out appendicitis, they're allowed to do that. But if you were in the doctor's office and you were seeing a patient for possible appendicitis, you can't code that. You have to code lower or upper quadrant right pain, fever, nausea, vomiting. Those are more symptoms, technically, than they are of a real diagnosis. But you don't have one because you don't know, because you can't do an ultrasound and definitively say, oh yeah, that's high. Or you can't draw the blood counts to see that their white cells counts are high. So there are going to be reasons why you do need to code symptoms over a real diagnosis code, but that's where these code guidelines come in on page G23. And they do have a few little guidelines there, but nothing major. Just know that routinely this paragraph in here in B is exactly what you need to know. You need to usually do your definitive diagnosis and the symptoms following if you're going to diagnose any symptoms, but we just normally do not do symptoms. We try not to, but you're not going to be able to get around it. TIAs are never coded unless the patient is having that cerebral effect in front of you. If they have a history of TIAs, you definitely diagnose the history of, but they cannot have TIA in your office. If they do, you're calling an ambulance and getting rid of them. So be careful when you're diagnosing that one, and don't pick that answer that TIA is first unless the documentation says on the question that they're having that event right there in front of you. It's one of the most misdiagnosis codes and over-reported diagnosis codes in the regular real life doctor's office visits. Injuries. The injuries scenarios that I had for external causes were burns, and then I had a baseball injury, I had a bar fight, and then I had a chainsaw accident. So knowing the sequencing of external causes was very beneficial, but like I showed y'all earlier in the live, we negated that by writing which external codes are coded first in several areas in the ICD-10 book so that we kept that straight for that kind of information. Burns, the rule of 9, each body part, limb, extremity is worth 9% of the surface body area. It changes for babies because their bodies are built differently than ours. So their scenario is different than adults. So you can't even use that rule of 9 in the burns for children. Here's our external causes that we've got to. The cause of the injury, the intent, the place, the activity, and status. That's the way they go. Not too hard. Most of those scenarios are done perfectly for you. What's over here? Oh no, there's that suspected. Okay, abuse. There's some abuse codes and complications due to transplants. Doesn't y'all still there? There we go. Hopefully y'all are still there. Too difficult here. We've got suspected abuse or known cases of abuse, but most of the time it's always going to be the T code first, and then what acquired injury is next, and then if it's an assault, there's going to be a Y or an X code for that. But they both are going in the same direction, whether it was intentional or accidental. So not too bad there. Medicare does not recognize any external causing codes, so they don't even want to know or care how the patient was injured. They just want to know where was the injury and was it treated with whatever CPT code. Just in the real life world, you won't charge or bill external causes with Medicare patients. Anything else? Y'all know that we do the Z20 code for well child exams, those kind of things. And then they have some history of, family history of mental health issues to other conditions. Polycystic kidney disease is super important to know if parents are having kids that have history of that. But those are all secondary codes. You won't use those as a first code unless they're here for a well child or a wellness exam and chemotherapy, radiation, those kind of things. But that's pretty much it. We went through the whole guideline section for all of those. Yep, they're all the same. That's it. Then we have our practical setup for this CPT book or the ICD-10 book. And then they even have a list of how to use this to pass your credentialing exam. So they tell you not to glue or post anything in it, but they definitely want you to highlight. They definitely want you to move guidelines to the sections where you need them. They don't mind you writing in them all you want. Let me show you this one from this beginning of this that I did. These yellow lines that are coming down in this ICD10 are super important. If you have an acute diagnosis and a chronic diagnosis on the same yellow line, then you can diagnose it on the same visit for the same day. You would do acute first, and then you would do chronic. So these are called levels. So thyroiditis, this EO6, is not at the same level as I was trying to find one without EO6 in it, but I guess they're all under EO6. But EO6O to any of them are all going to be different than your main one that's stuck out here, the 109. They're at a different level, but acute and chronic are at the same level. A lot of these diagnosis codes do have acute and chronic in them, but if they're not on the same line, and even if it's not the yellow line, if it's not the white line, this one right here, they have to be under the same level on this index, this one specific, to even be able to be diagnosed in the same visit for the same day. And then I moved all my guidelines for external causes right here. It's never coded first. I even put the blue highlights in there. So if you go to status under this, everything's going to be color coded just like what it is, so you know which one to do first. That green section is status. So green would be the last thing you would diagnose, which is either they were doing a hobby, they were in the military, they were a recreation, they're civilian, they were a child assisting, they were volunteering, whatever they were doing. Their status would be blue is intent, whether it was suicide or not. And then I even moved them to the back of the book and wrote them near the front of those codes. So anything that you have guideline related, I would move to the actual real diagnosis codes. That will help you out. But it is just 10 questions. Come on, camera. And it's not going to make and break you if you get the other 100 correct from the CPT book, for sure. You're going to know some of them, that's for sure. And all the pink codes were the codes that were on my CPC exam. They really liked this section. We're under digestive system. Oh, yeah. Scopes. Are they open or closed procedures? It's going to be one of your questions. I like to write to where I'm at in the body at the top so that I know if I'm in the right section or not. See? That helps you during your exam. Scopes are closed procedures. How you can tell the difference is if a doctor is looking through a machine at the body part, it's a closed procedure. If they have that body splayed apart and the doctor can physically look with his eyeballs at the organ or thing that he's messing with, then that's an open procedure. A lot of these questions are going to be based off whether it's opened or closed or something like that, for sure. Be sure you have some scenarios down for each page in the CPT book, noting the differences, noting when you can't use a modifier, when you can use a modifier. There's one question on the CPC exam. It says, which of these CPT codes can be modifier exempt or something. It's got random codes from the 2000s all the way to the 9900 codes. The answer is always going to be this modifier 51. There's a set random list in the back in one of the appendix that lists out every one of the codes. But they also have this 0 with a line through it that tells you not to use it. But if you run across that question and it's just got random CPTs and it's asking you which modifier is exempt, the answer is always this one right there. They like to pick on that one for some reason. Are there any other questions before we get off this live? I've been on for 2 hours. And I will post this on YouTube to let everybody know, so they can watch it again, catch what I haven't said or did say. Kids. I hear the cartoons going on. Here's all the websites. If you want a free practice E&M exam, I have that about midway down. You just go to that website, scroll down to the middle. You don't have to sign up on the website. It's just 10 E&M questions right there. They're pretty difficult because they're post-CPC exam certification questions. Nobody gets question 2 right, but they're there, and it's good practice because it's free 10 questions. Of course, I got all my TikTokies here. I repost all my lives on YouTube there. I have an email address. A link is in the bio. It's on my picture here on TikTok. I have the email address there, and I have a list of all the pages in Etsy there. So if you want a scanned, gosh, this stupid camera, page by page pages of my CPT book, they're all listed there on Etsy. We have a messenger chat group right there too if you ever want to join. I have Messenger is under Jen Brewer, same profile pic. Just message me there and you can join in. We all sit and talk. Look, I'm not trying to type, but we all talk and congratulate each other when we pass and talk about codes. I give out cheat sheets all day, talk about scenarios, what would be on the exam, what people are saying are on the exam. I have one message from somebody today who was just showing me what was on her exam. She had some questions. These were on her exam. She didn't know what they were at some particular point. Remember, I was asking about the skilled Medicare program. That means what part of Medicare paid for what skilled nursing is. She didn't know what an ABN was, and maybe that diagnosis code, ARDS, something about this. So everybody lets me know what they've had difficulty with on their exam, and we discuss it in our little chat group too all day when we're not on here. Hey, Marisol, nice to meet you. I used to work with somebody named Marisol. I miss her. She's so nice. You're very welcome for all the information. Miss Jess, I'll talk to you tomorrow. You get you some rest. And I'll be doing another live on Friday. And again, I post them all on YouTube if y'all need them. Be sure and email me any questions y'all have, or let me know anything y'all want to go over in live, and I'm happy to help. Thanks, guys.